Assalamu alaikum wa rahmatullahi wa barakatuhu. Welcome back to the channel of Science Medical Notes and Lecture. So let's move on forwards. So having diagnosed a patient with diabetes and having known the pharmacological framework for a patient with type 2 diabetes mellitus, we should know about the routine investigations which are done at the time of diagnosis of type 2 diabetes mellitus. So let's look on that. So routine investigations. So newly patient who is diagnosed with type 2 diabetes mellitus. So what is our goal? To know the number one is to know the glycemic status. Number two is to screen for microvascular complications. Number three is to screen for macrovascular complications. How you will screen for macrovascular complications? By knowing the cardiovascular risk. Okay. So to know the glycemic status, to screen for microvascular complications, to screen for macrovascular complications. Now to know the glycemic status, two things you will do. One is HbA1c, which is the gold standard for long-term control. So if HbA1c is more than or equal to 6.5, then it is diagnostic. So you should perform order HbA1c. Second is you should always know fasting plasma glucose. So more than or equal to 126 milligram per deciliter is diabetes. So these two investigations are of paramount, okay, to know the glycemic status. So a confusion arises. So what about postprandial glucose or prandial glucose? Prandial glucose. So first of all, we should stabilize fasting plasma glucose and HbA1c. Remember one thing. Now, if fasting plasma glucose is in the target range but HbA1c is still raised, then you should stabilize prandial glucose. So this rule you should remember always. Okay, there prandial glucose has its importance. Now for microvascular screening, so three things you should see. Number one is renal profile. So measure serum creatinine. So from serum creatinine only you will derive eGFR, and measure urine albumin creatinine ratio. In some regions UACR is not possible, then you can measure urine protein creatinine ratio, okay, UPCR. So serum creatinine and UPCR you should measure for microvascular complication. So this will detect early nephropathy. Second thing is fundoscopic examination, meaning dilated eye examination to check for diabetic retinopathy. Approximately 21% of type 2 diabetes mellitus patients have some retinopathy at diagnosis. That's why eye examination is recommended at the time of diagnosis in patients with type 2 diabetes mellitus, whereas eye examination is recommended after 5 years of diagnosis in patient with type 1 diabetes mellitus. That is the difference we should remember. Okay. Not only eye examination, both renal and eye examination, and all these micro and macrovascular complications in case of type 1 diabetes mellitus occur late. That's why it is recommended late. So after 5 years of age, you should screen for these complications in case of type 1 diabetes mellitus, whereas they occur early in type 2 diabetes mellitus. That's why you should screen initially at the time of diagnosis. So renal profile you will perform dilated eye examination, preferably by an ophthalmologist. It should be done. And third thing is in microvascular complications, it is comprehensive foot examination. In that, what you will do, you will measure the pedal pulses, particularly mainly two pulses: posterior tibial artery, which is behind the malleoli, lateral malleoli, posterior tibial artery pulsation you should see on both sides of the limb. And second is dorsalis pedis artery pulsation. Dorsalis pedis artery. Okay. So these two pulsations. Second is sensations. So in sensation, so first sensation which is lost is vibration sense. So tuning fork. What do? You just hit a tuning fork, and when it is vibrating, you put it on the one of the malleoli, either medial or lateral. Okay. And when the patient says that I'm not feeling vibration sense, you just put it on a bony point of your body, and if the timing is same, meaning if the patient and you both are feeling that the sensations the tuning fork sensation is lost at the same time, then that means the patient is not having loss of vibration sense. That is one thing. Second thing is, you can do a monofilament test, 10 gram monofilament test. So in this test, what you will do, you will have a 10 gram monofilament, and you will check for 10 points on the sole. Check if this is the sole. Okay, 10 points will check here, 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 at the tarso-metatarsal joints and the first interfaleal joints. 10 points will measure. If 8 out of 10, at the 8 out of 10 places, if this is not felt, this 10 gram monofilament touch is not felt, then the patient is very much high risk for foot ulcers. So that's about the microvascular complications in patient with diabetes mellitus. So these things we should do at the time of diagnosis: renal, eye, and that. For macrovascular complication, so mainly we will measure cardiovascular risk, measure the lipid profile, total cholesterol, HDL, LDL, and triglycerides. Second thing is measure the blood pressure. Okay. Third thing is order liver function tests to screen for non-alcoholic fatty liver disease. Okay, non-alcoholic fatty liver disease. So these things you will do for macrovascular complications. You will perform lipid profile, you will order a baseline LFT, and you will see the BP. So these three account for macrovascular disease, and if they are not in targets, then you will bring those in targets by therapy. Okay, so in lipid profile mainly you will see LDL and triglyceride level. Blood pressure is targeted less than 130/80, and in liver function test, if they show fatty liver, non-alcoholic fatty liver disease, meaning so ultrasound, it will be very much easy that you see fatty liver in ultrasound, but in LFTs, if you see two times, more than 2 times elevation of SGOT and SGPT, then that means patient is having NASD, meaning non-alcoholic steatohepatitis, NASH. So this is not a good thing actually. Okay, so baseline LFT you see, and if you want to see obvious fatty liver, you should go for ultrasound. Okay, there if you see fatty liver, then that also is a factor which gives you a clue for macrovascular disease. Then you should, so when you treat lipids, your fatty liver also resolves. So but therapy also will shift towards GLP-1 agonist and pioglitazone now, if fatty liver is present. Okay, so these are the investigations. Just to summarize, so our main goal is to know the glycemic status, know the microvascular complications at presentation, and macrovascular. For glycemic status, we will do HbA1c and fasting plasma glucose. For microvascular complication, we will have baseline renal function test, dilated eye examination, and foot examination, comprehensive foot examination. For macrovascular complication, we will have lipid profile, hypertension, and baseline LFTs, preferably if possible with ultrasonography, because in ultrasonography you can make out fatty liver very easily. Okay, that's about the investigations at the time of diagnosis. Okay, now coming to drug treatment, non-insulin pharmacotherapy. Okay, non-insulin pharmacotherapy. So first we'll know the mechanism of action of these drugs which are used for type 2 diabetes mellitus. Okay, where they act, you can see at the left side. They will act on liver, number 1. They will act on pancreatic beta cells, number 2. They will act on gut, GLP-1 receptor agonist or incretin modulators. Number 4 is kidney, SGLT2 inhibitors. Number 5 is skeletal muscle, so those which increase the insulin sensitivity, like thiazolidinediones. So these are the 5 groups of drugs. They act at different site. So one is liver. Example for that is metformin, okay, which acts on liver. Pancreas is sulfonylureas, okay, beta cell. Gut is GLP-1 agonist and DPP-4 inhibitors, okay. Kidney is SGLT2 inhibitors, and skeletal muscle is pioglitazone, okay, pioglitazone preferably. So these are the 5 sites of action mainly. Now we will see. So high blood glucose, see biguanides, mainly metformin, they act on liver. What they will do? They will decrease the gluconeogenesis, decrease glycogenolysis by AMP kinase activation. Hence, they will decrease the endogenous glucose output. And also, this metformin decreases the insulin resistance, meaning it increases the insulin sensitivity. So, thus they will decrease the blood sugar. Mainly fasting plasma glucose, and both fasting plasma glucose and postprandial glucose are reduced. Both are reduced, but the main thing is they increase the insulin sensitivity. That is very important. And coming to those which act on the muscles and adipose tissue, that is thiazolidinediones. What they will do? They will increase the insulin sensitivity. This is very important. So how they will do? By PPAR gamma activation. What is this PPAR gamma? Peroxisome, that full form is peroxisome proliferator activator enzyme, activator receptor gamma. So actually this is a receptor which is situated in the nucleus, in the DNA. So these drugs, what they will do? They will go and bind to that receptor which is present in the nucleus, and transcription will take place. From transcription to translation. So translation, what it will do? It will cause increased production of GLUT4 transporters, meaning increased PI3K pathway will be there, okay. So GLUT4 is very important for insulin uptake by the cells. So that's how they act, this pioglitazone, okay. They increase the insulin sensitivity by PPAR gamma activation. And so which act on your pancreatic beta cells? They are sulfonylureas like glimepiride, gliclazide, glipizide, and meglitinides like rapaglinide and nathaglinide, okay. Again, they will also cause increased insulin secretion by closing the ATP dependent potassium channels. So those which act on the gut are 2. One thing is incretin based therapies. Second are alpha-glucosidase inhibitors. These are not very much used, because they cause a lot of GI adverse effect. So DPP-4 inhibitors, example is sitagliptin, and second is GLP-1 receptor agonist, example is liraglutide, semaglutide, okay. So these are the drugs. So they will accelerate the amplify the insulin release after meals, mainly after meals, okay, by increasing the insulin secretion and decreasing the glucagon secretion. That is one thing they will do. And they will also act on gut. They slow the gastric emptying, so patient will so slowly the glucose is absorbed into the blood. So by slowing the gastric emptying, the glucose is very much slowly absorbed into the gut. So thus your glucose is homeostasis is maintained. Third one is they will act on the brain. They increase on the satiety center of the brain, and the patient will feel that he will take small amount of food, and he will feel that, oh, my stomach is full now. So that is how they act. So they will increase the insulin secretion, decrease the glucagon secretion, and they will they will have an incretin effect. Second, they will act on the gut by reducing the gastric emptying time. Third, they will act on the satiety center of the brain. Alpha-glucosidase inhibitors, they will inhibit alpha-glucosidase enzyme, which is responsible for breakdown of starch into simple glucose, and thus because there is starch is not broken down into simple glucose. So body can't take starch directly, it has to be broken down to glucose. That's how glucose is not absorbed. Now what will happen, the side effect is this starch and this disaccharide, all the disaccharides like fructose, sucrose, okay, these will move on to the colon. In colon, there is colonic bacteria. Now this will take advantage of this. So this colonic bacteria will utilize these disaccharides and starch, and this will cause gases in the patient, increased flatulence, and increased abdominal bloating and belchings. All these things will be there. Patient will be very much uncomfortable. So okay, the drugs are there, but I don't use these drugs very much. I don't use only these drugs actually. Okay, that is how these drugs act. The last one is the drugs which act on kidney. Example, empagliflozin and dapagliflozin. So SGLT2 inhibitors expression is increased in case of diabetes mellitus, and hence glucose absorption is increased in the proximal convoluted tubule in the kidney, increasing the blood sugar. So when these are inhibited, so glucose is excreted into the tubules, and thus that decreases your blood sugar level. So these are the main mechanism of action of these drugs. Okay, so just to summarize, so the main drug classes which you use are Biguanides. Number one, very much important drugs, metformin. Okay, fenformin was there, but because of increased risk of lactic acidosis, it is not used. Thiazolinediones, pioglitazone. Rosiglitazone is not used because of increased risk of bladder cancer. Sulfonylurea, okay, Meglitinides. So these two act on pancreas. This acts on adipose tissue and your skeletal muscle. This acts on liver. DPP4 inhibitor and alpha-glucosidase inhibitor. These act on gut. Okay. GLP-1 receptor agonists, they act on pancreas, brain and gut. SGLT2 inhibitors, that acts on your kidney, nephrons. Now coming to specific diabetic drug category. Okay, so coming first to Biguanides, the first line drugs. Okay, so metformin, dosage initially is 800 or 850 mg per hour once daily, taken with largest meal. Dose is increased by 500 mg per week up to usual dose of 1000 mg twice daily with meals. Maximum dose is 200 grams. Mechanism of action you already know. Efficacy, so HbA1c reduction is actually 1 to 2% only by this metformin. Contraindications are renal failure, eGFR less than 30, that is a contraindication. Okay, or in terms of creatinine more than 1.5 in men or 1.4 in women is a contraindication. Or severe hepatic dysfunction, second contraindication. Or decompensated or advanced heart failure, acidosis, hypoxia, shock. Okay, so what these conditions, why it is contraindicated in these conditions? Because there is a risk of severe lactic acidosis. This is also known as MALA. What is MALA? Metformin associated lactic acidosis is known as MALA. So in these conditions, the risk of lactic acidosis is very much increased. So that is well known in renal failure and severe hepatic dysfunction. But in advanced heart failure, the tissues are already hypoxic. That's why there is increased risk of severe lactic acidosis. Shock, again lactic acidosis. Hypoxia, again lactic acidosis. Acidosis, again increased risk of acidosis. So okay, that is these things we should remember. So contraindications we should remember. Okay, efficacy, mechanism of action we should remember. We remember frequent adverse effects that are not diarrhea, nausea, vomiting, bloating, abdominal cramping and metallic state. See risk of hypoglycemia, no risk of hypoglycemia if used monotherapy. Effect of weight, so it is weight neutral actually. Okay, now miscellaneous disadvantages you should see. So very well known to cause B12 deficiency, this metformin. Okay, very important. And another important thing is, in patients, the metformin should be discontinued in patients undergoing radiological studies where intravascular iodinated contrast media is used. So in meaning, if the patient is undergoing contrast enhanced scanning like contrast CT scan or contrast MRI, then their metformin should be discontinued temporarily. So Main thing is B12 deficiency. Okay. So this is important. Other comments, GI adverse effects are more frequent early in the course of treatment. Extended release formulation, slow release formulation of metformin may be better tolerated in patients with GI adverse effects. Elderly patients should not titrate to maximum dose, and same is the case for patients who are having your kidney disease or liver disease. They should be titrated to half of the dose, that is 1000 mg in this case. Okay. Careful use in patients in equal to or more than 8 years of age. Normal renal function has to be established in these patients. Okay. So I think you have understood all about this. Okay. So this much of information is given. We should remember only those things which should be known. So one is dosage, how they are, dosage and maximum dose, and efficacy you live. You should know the contraindications, very important, and you should know the frequent side effects, that is important. You should know whether there is a risk of hypoglycemia, and you should also know effect on weight. Okay. Sixth one, you should know disadvantages. Okay, that is B12 deficiency, and other comments, some important points in other comments. Okay. Now moving on to this other category of drugs. So the other category of drugs is sulfonylureas, commonly used. Okay. So in sulfonylureas, you are seeing glipizide here, glimepiride here. Okay. Glyburide. Glyburide is nothing but glibenclamide. Glibenclamide is glyburide, and gliclazide. But the most commonly used drugs are number 1 glimepiride, number 2 gliclazide. So glipizide and glibenclamide, they are not used. They are usually not used. Okay. Maybe some physician may be using, but the most commonly used drugs are this glimepiride and gliclazide. Why? Because glimepiride is a long-acting drug, and it has another action, that is, it increases peripheral insulin sensitivity also, in addition to increasing the release of insulin. That's why glimepiride is very much commonly used. Second common drug used is gliclazide. Why? It has antioxidant properties, but always it is used in MR form in normal patients who are not having any CKD, and also in normal form, meaning not in extended release formulation, not in ER formation, normal gliclazide formulation. They are used in CKD patients also. Why? Because they are very much short acting. They will act for 4 to 6 hours. That's all. Okay, that you should remember. So these two drugs are very much commonly used. So if you want to remember the dosage of this, I just explained. So glimepiride is used at 1 to 8 mg per oral once daily. Adminol once daily with breakfast or first main meal of the day. Titrate in 1 to 2 mg increments. Maximum recommended dose is 8 mg per day. Remember one practical important point. Even though the maximum dose is 8 mg per day of glimepiride, but 90% of action of glimepiride is completed at 4 mg dosage only. This is a practical point to remember. So when you reach 4 mg, that means 90% of the glimepiride action is done. Okay. So no need to go for 8 mg. You can try up to 6 mg, but 8 mg is not good. You should meaning if you are going to 4 to 6 mg, then you should have in your mind that beta cells of the pancreas of the patient are shut down now, totally shut down, 100% shut down. That you should have in your mind. Now gliclazide. So either it can be used in immediate release formulation. So in immediate release formulation, it is used at 80 mg dosage thrice daily. So maximum dosage is up to 320 mg. Okay. 80 mg TID you can use. So maximum up to 320 mg per day you can give in immediate release formulation. Whereas in extended release formulation, you use it in 30 mg once daily or twice daily also you can use, BD or OD, and you can go up to 60 mg twice daily. Maximum dose is 60 mg twice daily in case of extended release formulation. Okay. So these two drugs are very much commonly used, just to remember. So extended release formulation is used in normal patient, not in CKD patient, and immediate release formulations are preferred in CKD patients. Okay. Okay, this is the information. So mechanism of action already you know. So contraindications you should know. So patient who are having hypersensitivity Frequent adverse effects you should know. Hypoglycemia is sulfonylureas, hypoglycemia is the most common adverse effect. So risk of hypoglycemia is very much high. That's why carefully they should be used in elderly patients. Okay. And this is also important. They cause weight gain. So patient who is already obese, try to avoid this sulfonylureas. Miscellaneous disadvantages is failure rate may exceed other drugs. That is important. This is attributed to exacerbation of islet cell dysfunction. What you are doing, you are forcing the limited cells, beta cells, which are available in the body to produce more insulin. So they will also fatigue and they will die very much early, because we are forcing the, so if 100% of cells were active in normal patient, so 80% have due to apoptosis they are gone, and remaining only 20% are there, and you are forcing the 20% of cells to do the work of 80% of cells. So that means you are putting more pressure on these 20% of cells, so they will die early. So that is the disadvantage. Other comments: reduces postprandial glucose excretion. This is important point. Postprandial, after meal glucose excretion, it reduces. That's why it should be given in the morning time. So you should start with low dose, increase by 1 to 2 weeks based on blood glucose. Patients with decreased caloric intake or fasting may need doses held to avoid hypoglycemia. If you are not taking food, you don't take these sulfonylureas. Long-acting sulfonylureas like glyburide is nothing but glibenclamide, may be associated with higher risk of hypoglycemia than short-acting sulfonylureas. Short-acting meaning, compared to this glibenclamide, these are short-acting. But these will also act, this glipizide act for 12 hours, it is given in BD doses, whereas glimepiride acts for 24 hours, it is given OD doses. Okay. Same is the case for gliclazide MR release formulations. So I think you have got much more information. Okay. Now coming to the other class of drugs, that is meglitinides, also known as glinides. So number 1 is repaglinide and number 2 is nathaglinide. So nathaglinide is not used. If used, this repaglinide is used. So used at the doses of 0.5 to 4 mg per orally, 1 to 30 minutes before each meal, 2 to 3 or 4 times step based on the meal pattern. Okay. Titrate in 1 to 2 mg increments weekly. Maximum recommended dose is 16 mg per day. Okay. I am not going to discuss nathaglinide. So commonly used drugs, these are not used mainly. Okay. These drugs are usually they are not used, meglitinides. Okay. Mechanism is same as that of sulfonylureas. Contraindications, you know, hypersensitivity reaction. Frequent adverse effect is headaches. This you should remember. Headaches are the frequent adverse effect. Risk of hypoglycemia is present. So they cause weight gain. Okay. So advantage here is actually short duration of action allows for dose flexibility. They are very much short acting. So they are like regular insulin. If a patient taking regular insulin just before food, or ultra short acting insulin just before food to reduce post meal glucose hype. So like that you are taking oral glinides. Okay, they are very much short acting, 2 to 4 hours just they will act. That's all. Okay. So dosing is, that's why TID dosing, and they are expensive. That is the drawback. So they reduce postprandial glucose excretions. Repaglinide is more effective at lower HbA1c than nathaglinide. Okay, repaglinide is principally metabolized by liver, less than 10% excreted kidneys. That's why these drugs can also be used in your CKD patients. Okay, because short acting, that's why low risk of hypoglycemia. And they are not excreted kidney also. They are mainly excreted by liver. Okay. If patient misses a meal, glinides should not be administered to avoid hypoglycemia. Same to the top. Okay. So one important thing about meglitinides is you can use in CKD patients. If patient is not willing to take short acting insulin before food, you can use it in CKD patients. So before food you can give these drugs, and by measuring postprandial glucose levels, you can adjust the dosage, and instead of giving your insulin, you can give these drugs if the issue is only postprandial glucose excursions. Now we will move to other group of drug. This alpha-glucosidase. This is not used very much, okay, as I said. So here it is, he has given this from McMaster textbook of medicine, acarbose, but commonly used voglibose in the dosage of 0.2 to 0.3, okay. 0.2 is considered as low dosage, 0.3 is considered as high dosage, okay. Mechanism as already said, so alpha-glucosidase inhibitors. So mainly they will reduce the postprandial glucose levels. Contraindications: severe hypersensitivity reaction, inflammatory bowel disease, colonic ulceration, any condition, any problem with GI tract, okay. So patient with dyspepsia should not be given this, and patient who are having liver disease, cirrhosis, no, should not be given. Renal impairment, creatinine more than 2 mg per deciliter. So that means in CKD patients, in liver patients, and GI condition patients, you should not use these drugs. Frequent adverse effects: flatulence, diarrhea, abdominal pain. You remember just these things. Risk of hypoglycemia, no risk. Effect on weight, actually they cause weight loss. Remember, here it is given neutral, but they cause weight loss actually. And disadvantages: frequent GI adverse effects. That's why they are not used. So they mainly reduce postprandial glucose excursions. In case of hypoglycemia, example, concomitant use of sulfonylureas, glucose recommended for treatment. Okay. So GI adverse effects may be decreased by restricting dietary sucrose levels. But we don't use this. Maybe it depends upon the physician, which drugs he is using. Okay, which drug he is constant. I don't use this because in my experience, patient have a lot of GI adverse effect. He will quit the drug by adverse effect only. Okay, that's why. And these are very good drugs. Thiazolinediones. I use these drugs very much, mainly this pioglitazone. Why? Because they increase the insulin sensitivity very much. So if previously glimepiride patient was not responding to glimepiride, if you give this thiazolinediones, he will respond to glimepiride, or the dose of sulfonylureas get reduced. That's why they are very good drugs, but they have drawbacks in some conditions. So that we will see. So rosiglitazone is not used because of very much risk of high cancer. So I will discuss only pioglitazone. The dosage is 15 to 30 mg per oral once daily, okay, without regard to meals, okay. So if you want to increase in 15 mg increments. Maximum dose is 45 mg once daily, or you can divide into 15 mg TID also, okay. Mechanism is they will increase the insulin sensitivity, as I said. They are very good drugs in my opinion. Some physicians don't use this pioglitazone. They prefer voglibose like thing, but I don't prefer voglibose like thing. So contraindication is hypersensitivity reactions. So any condition which increases your volume overload, which creates a volume overload state in your body, that condition you can't use because it causes weight gain, okay. So like CHF you can't use, okay. Or in CKD patients also you can't use these drugs. And serious hepatic impairment, because these are metabolized by liver, so you can't use. Bladder cancer you can't use, okay. Pregnancy you can't use, that's well known, okay. Frequent adverse effect is edema and headache. So where headache, again Meglitinides headache was there, so edema and headache is the frequent adverse effect. So patient can have CHF exacerbation. There is an increased risk of bone fractures, anemia, bladder cancer, okay. They cause weight gain like sulfonylureas, okay. Miscellaneous advantages: they increase HDL, decrease triglyceride. That means they are improving the lipid profile also, because they act on adipocytes also, no. That's why they make the lipid profile good. That you should remember. Some comments: limit maximum dose of pioglitazone to 15 mg per day, and consider dose reduction of rosiglitazone. See, this is a very practical comment, because in my practice I have seen, if I just increase the dose to 30 mg, no, patient will come with breathlessness. So this is a very practical advice. Always limit the dose to 15 mg, or maximum you can add 7.5 to this, 22.5 mg. Practical advice, okay, but theoretically 45 mg is given. But if you move to 30 mg now, patient will definitely come with peripheral edema or breathlessness because of volume overload. Okay, we will now move on to the next category of drugs, that is DPP4 inhibitors. We need to finish this. So I will discuss only these two, sitagliptin, because these are very much commonly used. So it is given at a dose of 100 mg per oral once daily, administered with or without food, no relation with food. But remember, if the EGFR is between 30 to 50, meaning for example CKD 3A, if the patient is in CKD 3A, dose should be halved. That is 50 mg once daily. And when the patient reaches CKD 3B stage, meaning less than 30 EGFR, so dose should be 1/4 mate. Okay, so that's why in CKD this sitagliptin is not used. So instead linagliptin is used. This does not require any adjustment in CKD patients. So this is given 5 mg per oral once daily. Okay, no dose adjustment is required for renal. That's why in renal patients you prefer linagliptin. In normal patients you give sitagliptin. Mechanism you know. Contraindications. So this is important. Patient who are having acute pancreatitis, okay, you should not use this drug. Okay, and saxagliptin, one important point, similar to pioglitazone. So saxagliptin also causes volume overload state. That's why you should not use in congestive heart failure or CKD in these things. Saxagliptin. Okay, so this is an important adverse effect. Acute pancreatitis they can cause. DPP4 inhibitors. Generally they are well tolerated. Okay. Nausea is a very much common effect. Patient will feel dyspepsia, nausea like thing. Okay, there is no risk of hypoglycemia. Weight neutral they are, and they can be used in patients advanced renal disease also. Okay, that's all about DPP4 inhibitors. Moving on to GLP-1 receptor agonist. So we should learn this in very important point, okay, because these are very much commonly used drugs. GLP-1 receptor agonist, you have exenatide, liraglutide, albiglutide, dulaglutide, semaglutide, but I will discuss just the common one, that is liraglutide and semaglutide, because these two are very much commonly used. Okay, so liraglutide, the difference between liraglutide is short acting. It should be given daily, whereas semaglutide is long acting, so it is given weekly. This is given weekly, this is given daily by subcutaneous injection. And there is also oral formulation of semaglutide, but liraglutide lacks oral formulation. So first, liraglutide initial dose is 0.6 mg subcutaneous for first week. This dose is not therapeutic. It is intended to reduce, I will just zoom it, GI symptoms, but ineffective for glycemic control. Then increase to 1.2 mg once daily. So this is the therapeutic dose actually, 1.2 mg. The dose may be increased to 1.8 mg once daily, administered without regard to meals or time of day. Liraglutide is also indicated at a dose of up to 3 mg subcutaneously for weight loss in adults whose BMI is more than 27. So weight loss. So normally for diabetes up to 180 mcg is enough. For weight loss you can go up to 3 mcg. Okay, but slow titration is required, otherwise patient will develop adverse effect. What is that? Nausea, vomiting and diarrhea. These are the adverse effect. Loss of appetite. That's semaglutide is once weekly. Okay, this is costlier. This is not costlier compared to semaglutide. Semaglutide is costlier. So started at 0.25 mg once weekly for 4 weeks. Okay, after 4 weeks you will start at 0.5 mg once weekly for again 4 weeks. So this is the therapeutic dose actually. This is for tolerance. Now the therapeutic dose is 1 mg once weekly, and if required you can go to 2 mg also, but the maintenance dose is usually 1 mg once weekly. Oral semaglutide is 3 mg per day for 30 days, then 7 mg per day, This is the therapeutic dose. Okay, then maximum you can go up to 14 mg per day, 3 mg, 7 mg and 14 mg. Okay. Of note, semaglutide is also indicated at a dose of 2.4 mg subcutaneous weekly for weight loss. So I said maximum dose is actually 1 mcg for diabetes mellitus, similar to your liraglutide 1.9 mg, but weight loss dose of liraglutide is 3 mcg. Similarly, weight loss dose of semaglutide is maximum you can go up to 2.4 mg. 2.4 mg. Okay. So 0.25 increments you will increase the dosages. 0.25 increments. Okay. Okay. You will double, like 0.25, then 0.5, then 1, then 2 to 2.4. That's how you will move on. Okay. Similarly, if you look at 0.6, then 1.2, then 2.4, then 3, like that. Okay. Sorry, 1.2, then 1.8, then 2.4, then 3. This is 0.25, then 0.5, then 0.75, then 1, then 1, like that. Okay. Now coming to mechanism of action, already you know. Okay. So this is important. They have a proven CV benefit. Liraglutide, semaglutide and dulaglutide. They reduce the risk of MACE, stroke rather than CV death. Okay. That's why in patients who have a cardiovascular disease, GLP-1 receptor agonist must and should be included in the regimen. Okay. And also they reduce the CKD progression. So if SGLT2 inhibitors are not able, you can use instead of that this GLP-1 receptor agonist like liraglutide, semaglutide. They, okay, that one thing. Contraindications you should remember. Again here, similar to DPP-4 inhibitors, pancreatitis is a adverse effect. Hypersensitivity reaction is common for all. Severe GI disease, gastroparesis. So advanced diabetes 2 mellitus patients, they have this gastroparesis. So in that case, you can't use. Patient with family history of thyroid carcinoma or severe renal impairment, you can't use. So history of pancreatitis, severe GI disease, thyroid carcinoma, severe renal impairment. Frequent adverse effects are same nausea, vomiting, diarrhea, injection site reactions like poop. It is important. Injection site reactions are very much common. Headache, dizziness, nervousness. Okay. Risk of hypoglycemia is not there if monotherapy. Weight, they will cause weight loss. Once weekly preparation like semaglutide. Okay. This is important. GI adverse effects are more frequent early in the course of treatment. Administers as subcutaneous injection in the upper arm, thigh, abdomen. Some patients develop high titers of antibodies that may decrease the glycemic response. There is limited long-term safety. Oral semaglutide needs to be taken on an empty stomach with a sip of water and 30 minutes prior to any other peroral intake. Oral semaglutide. So that is 3, 7 and 14 mg. Okay. So what to remember here? Important things to remember here are they have proven CV and CKD benefit, and contraindications you should remember. Hypersensitivity reaction very common with this. Pancreatitis, thyroid, GI and severe renal impairment. 4 to 5 things. Frequent adverse effects you should remember. Okay. So don't bother about these things because I will give practical examples in the next video coming video after this. Practical scenarios we will see how to prescribe drugs with these things. Okay, so we will discuss there. So now GIP, dual glucose dependent insulinotropic polypeptide, and GLP-1 receptor dual action. That is only one drug, that is tirzepatide. This is approved as type 2 diabetes mellitus. Initial dose is 2.5 mg. Okay, 2.5 mg once weekly for 4 weeks. Then increase in 2.5 mg increments once weekly after 4 weeks. Up to 50 mg per week you can give. Okay, up to 50 mg per week you can give. Administer once weekly at any time of day with or without meals. Mechanism of action you know. So it causes weight loss. Number one drug for weight loss, tirzepatide. Contraindications you should know. So type 1 diabetes mellitus you should not use. Appetite suppression or treatment of obesity by other means. Again, thyroid carcinoma, okay, pregnancy, pancreatitis, GI disease, all these things you should not use. Frequent adverse effects you should know: nausea, diarrhea, vomiting, constipation, dyspepsia, abdominal pain, okay, that you should know. Pancreatitis, injection site reactions, and hypoglycemia risk is not there if monotherapy. Expensive, this is the main drawback. Other comments: inject on upper arm, thigh, abdomen, okay. Up to 15 mg per week you can give, okay, but we don't go to 15 mg actually. So next important class of drug is SGLT2 inhibitors, also known as Flozins. So I'm going to discuss only DAPA and EMPA because these two drugs are more commonly used. Canagliflozin, the important of canagliflozin is this can be used in CKD patient of any stage. No dosage reduction is required. Dosage reduction is required, but it is safe in CKD. It is safe in CKD, dosage is required. So actual dose is 300 mg. You can give 100 mg. That's all. Dapagliflozin, you can start directly 10 mg once daily. Okay, with or without food. Empagliflozin 10 mg. Maximum dose is 25 mg. Okay, DAPA and EMPA. Mechanism, you know. This is important. Proven CF by rate. Prove reduction of CKD progression. But one thing which is not there in GLP-1 receptor agonist is reduction of heart failure hospitalization. This is very important. That's why heart failure, may they have or they don't have this diabetes mellitus, you should prescribe dapagliflozin or empagliflozin in particular to patients with heart failure. So this is included in GDMT therapy, guideline directed medical therapy. Contraindications: severe renal impairment, you need to reduce the dose actually. Severe hepatic impairment, active bladder cancer, type 1 diabetes mellitus is a contraindication. Frequent adverse effect is candidiasis, vulvovaginal, increased urinary frequency, and polyuria. Thirst patient will experience. Okay. So one important thing is euglycemic diabetic ketoacidosis, and patient will have risk of recurrent urinary tract infections. Symptomatic hypertension can occur in elderly patients. Hypoglycemia risk is not there if used in monotherapy. Weight loss, slight weight loss you can see. Miscellaneous advantages: decrease the blood pressure. Empagliflozin has been shown to reduce mortality among patients with type 2 diabetes mellitus at high risk of CVT. DAPA and EMPA delay progression of CKD, improve CV outcomes in patients with heart failure, regardless of the presence of absence of diabetes mellitus. That's why I said. Miscellaneous advantages: they cause chronic glycosuria, modest glucose lowering efficacy, they are expensive. These are disadvantages of, and LDL levels may increase. Dehydration risk is there. Other comments: correct volume depletion prior to administration. They reduce postprandial hyperglycemia by delaying the intestinal glucose absorption. Okay, because SGLT2 receptors are also present in intestine, so they postpone this your prandial glucose. Okay. Warning: recent FDA review applied to all SGLT2 inhibitors pointed to risk of euglycemic ketoacidosis, serious urinary tract infections. This is important. Okay. No need to worry. We will have practical examples of each scenario of specific cases, how to prescribe this anti-diabetic medications. Okay, in the next video. So it is very much enough for today. So we'll come in the next video. Thank you.